Yep, we're live on YouTube now, Chair.
Okay. Good afternoon, everybody. And I welcome you to this Health Scrutiny Panel Committee meeting held on Tuesday, the 7th of September. Do we have any apologies for absence?
Yes, Chair, from Councillor Bell.
Okay. Anybody else? Any declarations of interest? Nope, don't see any. Right, minutes of the meeting held on the 13th of July. Have we all read them? Are we happy with them? Do we have a proposal to accept them?
Accept them, Chairs. Accept them, Chair.
Thank you, Dorothy. Thank you. Right, straight on to item 4. We've got Mark Adams here, the Director of Public Health, Health Tees, going to give us a COVID-19 update. Mark, over to you.
Okay, thank you. I'll just share this PowerPoint, hopefully. Can you see that?
Yeah, it's coming through.
Yes, we see that fine.
Okay. There we are. Okay. So where we're at the moment is, as you can see on that list, there's quite a lot of areas in the country with quite high rates of community transmission. So Middlesbrough currently 19th with a rate of 395 per 100,000. I think it went over 400 with the update today. Very early 400s, but it's you can see the cases by day as we've seen before. I think the 31st was the day after the bank holiday Monday, 31st of August, which is this big number here, and we tend to get sort of big numbers after weekends tend to come in, and hopefully this is a downward trajectory, but I anticipate we'll see that start to increase when the impact of schools reopening feeds into the numbers. You can see that our rates have been flat from the beginning of August at a high rate, what we would call sustained community transmission at between 350 and 400 cases per 100,000, and no real signs of slowing down, particularly at the moment. If you look at it by age group, worryingly, the 0 to 19s, this blue line is starting to increase before schools have come back in again already. The 60 plus is a little bit higher than we'd like to see it, but lower as a result of the significantly high take-up of vaccines in that age group. If you look at a more granular detail by age group, the blue line is within the last week. The orange is the week before that, and the grey is the week before that. You can see where particularly the 40 to 44-year-old group and these younger age groups here having particularly high rates of high community rates, and obviously when schools are back this week, I anticipate that we'll see these rates increase in this age group first, and then make its way probably quite slowly through the age groups as we've seen before. And then I'll just skip past that. The critical thing is really the impact on the hospital and harm caused by those high rates of community transmission. So the hospital rates, as you can see at this end of the graph, have kind of been in the 70s for quite a long time now, and we're a little bit higher than that, but have sort of plateaued at around about 70. The good news at the moment is the critical care figures are a little bit lower than they've been. They've been up to 15 before, so they're a little bit lower than that. Sorry, go back to that. And the staff absence was over 400 before, particularly when a lot of people were isolating through what was called the pandemic. So that's good in terms of the operational ability of the hospital, but that is a pretty high rate that we're seeing, but it doesn't appear to be massively adversely affecting the ability of the hospital to function with the usual kind of rate of admissions. I guess the issue will be what that rate is as we move into the winter, and the higher rates of emergency admissions that we traditionally see every year in the hospital, and the hospital's ability to cope with that, and the COVID inpatients. If you look at mortality, the diamond is the 5-year average mortality, and kind of anything over that is what's called excess mortality. In the red bits of the bar are COVID deaths within 14 days of death, and COVID diagnosis within 14 days of death. So we had a period where we didn't see any COVID deaths, but we're starting to see a small number coming through, and one reported in the previous week, and sadly 412 deaths since the start of the pandemic in Middlesbrough. Looking at the vaccination uptake, with 76% of people in Middlesbrough, of adults in Middlesbrough over 18, have had the first dose, and 66% have had the second dose, which is slightly lower than the national average. And if you look at that through the age groups, this graph that we've seen before, you can see the very high take up in the older age groups, diminishing as you get to the younger age groups, which is a mix of time since they've been available to actually have the jab, and less the sort of perception of personal risk of COVID obviously diminishes the younger that you get. But any other vaccination program, these numbers will be phenomenal, but obviously this is really critical that we get these numbers higher. And it's not detailed on here, but we've talked before about the unvaccinated over 50-year-olds. That number still is stubbornly high. It's above 4,000 for Middlesbrough. Over 50-year-olds haven't been vaccinated at all. So all of the pop-ups and so on that we've done have had an impact, but still there are some vulnerable groups out there that haven't been vaccinated. We need to bear that in mind when we're talking about community rates. And I think this is the final slide, just a little bit more granular detail. I'll get these details out through Scott, so you can look at this in a little bit more detail. But you can just see the at any age group, the social profile of the vaccination. So 80% uptake in Martin and 43% in Ayrsham, and so on through every age group, but obviously a much higher uptake in the older age group, as we've seen in the previous slide. David, you asked about communications and what have we done through communications. I think it's fair to say that it is a very tricky area to cut through on communications, because obviously there's been a lot of noise, not all of it accurate, but a lot of noise around COVID since the start of the pandemic, and it's occupied everybody's time throughout that period. But the approach that we've tried to take in Middlesbrough is to build a citizen-led approach, and primarily, well, building it on honesty, and being as clear as we possibly can about risks to individuals, and action that we're taking, action individuals and communities can take to keep them safe. And then what we've tried to do is work through communities and community groups. There's some examples there through the COVID Champions network that we developed, which is a mix of individuals that are COVID champions and VCS organisations that we've funded through a grant programme that are part of that network as well. And some examples there of Links Hemington videoing their youth workers talking about their vaccine experience. And the principle of this is that trusted voices in the community have more impact in that community than potentially an announcement from the council or somebody who people don't actually personally know telling them something. So there's a role for professional opinion and professional views, but actually peer opinion and peer support is really important in promoting particularly the vaccine, but also the what people can do to keep themselves and their communities safe, and promoting that your actions keep your friends and family safe has been a critical part of what we've talked about all the way through. And we've also worked with the football club and the university and various other partners just to try to promote vaccine uptake, promote safe practice in different examples. And we've looked at specific work in supermarkets, for example, school buses and sharing cars at certain times throughout. And when there's been specific issues like variants of concerns, we have done leaflet drops, advertising vans, and so on. So we'll continue trying to build that community capacity and community understanding approach to communications. But I think that is against the backdrop of it is quite difficult to get messages to cut through with the kind of other noise that's around COVID. So that's all that I had on the actual where we're at the moment. I can update on well, I can not necessarily update schools reopening. Obviously, they were testing last week and reopening today. I anticipate, as I've said, that we'll see an increase in rates in that age group first, and then it'll work its way through other age groups. There are limited actions that we can take through the contingency framework for schools. So if a school has an outbreak which is defined as 5 linked cases or 10% of a certain group, like a year group, and slightly smaller numbers for special schools, then we can advise on things like wearing masks in school and other mitigations which will have an impact, but not the same as sending year groups home. The principle of the contingency framework being to protect education as much as possible. We're working with the schools, and our aim is to support the schools and work with them to provide whatever they think they need to keep their children and families as safe as they possibly can. But our ability to act is a little bit limited under that framework. The final bit on schools, the 12 to 15 vaccinations, has yet to work its way through from the JCVI announcement on Friday. And as I understand it, the chief medical officers of the 4 countries that make up the United Kingdom are considering whether they would recommend it, that it will be 12 to 15-year-olds will be vaccinated. I anticipate that will be the recommendation, but we don't have those details yet. And if it is the recommendation, then we'll need to mobilise our school vaccination team and work with the schools very quickly to get that in place. The original intention was to get that by October half term. So if that is approved, we'll have to mobilise pretty quickly and work with schools pretty quickly to get that programme in place, and also, as we've done with the main vaccination programme, do everything that we possibly can to reduce the potential impact on inequalities through the uptake being profiled in the way that we've seen for other groups. I'll stop talking there, David, sorry.
Okay, thanks. Just to take you up on that one point you made about figures, I informed the members of my ward that Stainton was quite low, and then the Teesside Live next day published the thing. If you combine Stainton and Hemlington, it's the highest in the Tees Valley. So it goes on percentage wise. If you look at the figures, obviously, even if you add Stainton and Thornton and Hemlington together, there's a less than, say, in Central. But it was the stark figures there people are sort of getting concerned about, when, yes, it's not good, but Stainton and Thornton, for example, is quite low, and part of the ward is in Hemlington. It didn't seem right to group everything together like that, and people are saying, "Oh, it's terrible." Not quite as bad as it looks.
I think that just illustrates that statistics can be presented in all sorts of different ways that give different meaning. I mean, I think part of the honesty approach, we've tried to be as clear as we possibly can, but there are, for every clear, or what we perceive to be a clear figure that we put out, there will be a different figure that is put out through a different route that slices it up in a slightly different way, that appears to give a different message. I mean, that's been all the way through. That's been a bit of an issue, that different figures, they're all accurate, but they cut things up like geographies in a slightly different way, like you've described.
Yeah, because I see the figures. 402.9 is the 100k rate as of today. 95 new cases, which is slightly worrying. Sort of, it's plateaued. It's gone down and plateaued. It's about the level it was at the beginning of August. You remember last year, September was okay, and it went mad in October. So I'm just praying that the take up of vaccination should keep it down. And of course, as we know, it's hospital rates, which are really, really critical. Okay, anybody has any questions for Mark? Ron, you have a question.
Right, thanks, Chair. Yeah, going back to the chart with take-up rates per ward, I didn't quite have long enough to have a really good look at that. I was busy looking to try and find out where I was with my own particular ward. I did notice that 10 to the top there, Ayrson ward was right, very, very bad take-up rate. I mean, is there a link between the failure of the take-up rate and infection rates and death rates within that ward?
It's very difficult to determine a link in that way, because thankfully the death rates are actually quite low in statistical terms. So it's quite difficult to determine a clear link, because the confidence intervals on any of that sort of analysis generally tend to be very broad. We actually found, particularly when we were looking at the over 50s, we tried to see, was there a relationship between over 50s that were unvaccinated and those that ended up in hospital, and we don't have vaccination status of those in hospital at the moment. So it's quite, you know, there's a I guess there's an issue with the statistical the ability with the numbers that we've got to make those connections, and also we don't have complete information about those that are in hospital either. So I just view it as the wards with lower uptake are more at risk of harm, because if less people in that area are vaccinated, they're at more risk of becoming infected, having symptoms, being ill, and potentially being hospitalized. But actually proving a direct link with our numbers is limited at a national level. Clearly, those that are unvaccinated are at much higher risk of being hospitalized.
And follow on from that, can I just carry on from on the same thing? Is that the failure to take up rates, is that predominantly in areas that are more deprived than the better off areas? And why is that? Why is that, I ask?
Well, all across the country, that's the situation. If you look at the ranking that was for the Northeast, Northumberland's always at the top, which is a mix of an older population and a wealthier population. So I guess the less affluent you are, the more insecure your job's going to be, the more if you're concerned about side effects from a vaccine. And
it doesn't cost you anything, so I don't see what makes you. It's not a cost-based thing, is it?
No, I don't think it's a cost-based thing, but I guess it's that if you're getting shifts and you don't know what you're going to be working when, it's quite hard to book on when they were originally booked on. If you've got to travel from where you live to somewhere significantly far away, then it's going to be difficult to do that if you haven't got a car, and so on and so on and so on. So there's all sorts of potentially relatively small barriers that add up to. In any vaccination program, we always see that social gradient happen. There's an issue about what we talk about with vaccine is complacency, confidence, and convenience. So convenience is impacted more if you've got a car and you're more able to be flexible in when you can attend to be vaccinated. You're more likely to go than if you haven't got a car, it's further away, and your flexibility in terms of your work is more limited. So everything you look at will be you'll be disproportionately affected the least affluent you are. So it's seen in any vaccination program that we see that profile. There's an issue as well with BAME communities too, which have all of those issues, plus potentially language issues and other issues of understanding and different disinformation coming into those communities that exacerbate those issues in communities such as that. So that's part of what we've been trying to do through the citizen-led approach, is actually having direct conversations in those communities and trying to understand the issues that might make it difficult for people to attend. And while we've moved to more drop-in than bookable clinics throughout Middlesbrough.
All right, thank you.
Okay, anybody else? Dorothy, you have a question.
Yes, Mark. Really and truthfully, it's just due to the press, we've heard all about COVID passports, and I'd wondered if anything with regards to COVID passports and people attending nightclubs, etc., are going to have a COVID passport. Is this actually happening, or are you know as much as everybody else does?
I don't have anything other than what's been through the press, but as I understand it, the COVID passports for nightclubs and certain events, depending upon the numbers in the event, will happen. I think the aspiration to use COVID passports to try to encourage take up amongst certain groups, particularly younger people, is a reasonable thing to do. It doesn't appear to be particularly thought through in any way. It's a bit of a kind of scattergun approach, but my understanding is the announcements that were made will continue, and I think it's mid-October that you'll need a COVID passport to get into a nightclub. But I think you're all right, Dorothy. I think you've had yours, so you'll be able to get into all the nightclubs you want to.
There we go,
Yes,
Dorothy. You can go to town in Middlesbrough.
Maybe.
Yeah. Denise, sorry.
Thank you, Mark. Thank you.
Yeah. Thanks. It's Councillor Starry that's put the question through. Will there be any effect on the annual rollout of the children's flu vaccine if if we're going to vaccinate young people against?
Yeah, I think that is a worry, and of course the it will be the same staff group vaccinating both for the flu and for COVID. The aim is to do them together. There's a concern over, because parental consent's obviously important, we don't want the flu uptake to drop because you can only have it together, and therefore, you know, if I was a parent and I'm concerned about the COVID jab for whatever reason, and then that means my child doesn't get the flu jab either. So I think there's discussions about how we might deliver that if it gets approved, of course, and there are concerns about capacity. But as with all of these things, we'll make it happen because it's important, and if it does get approved, then we'll make it happen, and we'll do whatever we can from our side of it. Obviously, it'll be health service led to support and make it happen as much as we possibly can.
Thank you.
Thank you. Any other questions? If not, I'll thank you for your presentation. If you can send us a copy of the actual presentation as well. And it's a little bit worrying that it's going up at the moment, but hopefully with the vaccination take up and encouraging people, as many people as possible, to take it up, as Councillor Arundale said, you know, in as many areas as possible. You can see from the places where it's not taken up. So it's just to push it out, because I think countrywide it was it the first vaccinations up at 89.9%. It's something, it's very high. It's nearly 90% across all age groups from 16 to 100 plus. So that's important, and I just hope, you know, you can still catch COVID afterwards, but it's important. You shouldn't end up in hospital, which is the problem with the health service. So thank you very much. Thank you, Mark.
Thank you.
Look forward to your next update. Thank you.
Thank you.
Thank you.
Thank you.
Thanks, Mark. Chair, I've just notified Heather that we're
Yep.
ready for us, so it's just
Okay.
a connectivity thing. So if you just give us a couple of seconds. Oh, I think
Yep.
she's here.
Hello, I'll just be one more second. I'm just setting up a video for my children to watch while I'm talking. So just bear
No
with me.
problem.
I'll just turn the video off for a second.
Yep. No
Bye,
problem.
Anakin.
Great. Thank you. Yeah, so the next update will be which will be hospital inequality, health for wealth, Dr. Heather Brown of Newcastle University. It's a very important subject. It's one of the things that we talked about, and this is sort of the opening shots in that discussion. So when you're ready, Heather, when you get your children's video sorted out, we might want to watch it ourselves. It might be quite good.
Hello, sorry. Hello, everyone. Yes, I must apologize. I've just moved to Finland because I'm going to be working for the Finnish Public Health Agency, and so everything is a bit out of whack. So, and it's 2 hours later, so they're just finishing tea and very tired. But I'm going to be talking now about some work that I've been doing over the past, I guess, 5 years on health inequalities, and in particular health inequalities in the northeast of England. Okay, so now I'm going to try and share my presentation. Can everyone see that?
Yes, we've got your screen now. It's blank. Oh, yes, that's it. Thank you.
Is that it? Okay, I'm going to see. Let me try and get there. Okay. So, I said this is work we've been doing that looking at the link between inequalities in health and wealth, and how that impacts also on intergenerational inequalities. So today I'm going to talk about health and social mobility locally, regionally, and nationally, geographical inequalities in health and employment, some of the policy responses to inequalities, some of the research that we've done, the key findings, recommendations, and also key challenges. So, sorry, I have a little bubble in there, so I just have to move that. So this is looking at deprivation in the Northeast. So just under half of all of the lower super output areas in Middlesbrough are in the 10 most deprived in the country. And as you can see, this shows the index of multiple deprivation from 2015 and 2019. And in many places, it has been increasing. So one of the things that we've been working on is why this might be and how we can stop this increasing trend. So poverty rates are over 5 percentage points higher in the north of England compared to the rest of, oops, sorry, that shouldn't have moved. And child poverty rates, when I did the slide, were 29%, but they've increased to 33% in that time because of COVID in the northeast, and that compares to 21% in the southeast, and that rate has also increased, but I don't know it off the top of my head. But I know that in the northeast, it's 33% now. And that fuel poverty rates are also higher, and with the upcoming changes to energy bills, that's likely to also increase in the near future. So these figures are the 21% in the northeast. I think they were from, I'm going to say 2019. And then this just shows some of the projected economic impacts of Brexit. And you can see that the northeast of England in these projections fares worse than many other regions in the UK, with the exception of Northern Ireland. So why is the north falling behind? So part of it, sorry, this picture seems to have changed. So it's covering some of the words, but it shouldn't be in the slide that you have, the slides that you have. So deindustrialization changed the geography of economic growth and employment. And with this, there was a disinvestment in peripheral formal industrial areas. And this kind of was happening in the late 90s, early 2000s. And then after the financial crash in 2008, there was austerity from 2010 to about 2019, which also disproportionately affected areas in the north of England and the northeast in particular. So then thinking about health inequalities in the north, we can see that the regional health divide has been widening in recent years. For example, between 1965 and 1995, there was no health gap between younger northerners who are aged between 20 and 34 and their counterpart. But now, mortality rate is 20% higher among young people living in the north of England compared to the rest of England. And this just shows, this is from the Marmot report, which came out in February 2020, and it shows that life expectancy in the northeast is decreasing, in particular for women, but it's also been decreasing for men. And then we can also see that on average, earnings are more than 10% lower in the north of England compared to the rest of England. Sorry, I'm not sure why it's doing that. And economic activity rates are lower. So there's lower rates of people who are in employment or searching for employment. And then we've had the impact of COVID for the last 20 months. And that's been a tipping point for many families who were just getting by. Sorry. And we have rising levels of child poverty. As I mentioned earlier, there's been rising levels of food poverty. And as you can see in the last presentation as well, that there's been persistently high COVID rates in the northeast of England. So in one of our pieces of research, what we've done is that we've looked at 3 different policy periods nationally. So we've looked at the period 1991 to 1998, which was increasing neoliberalism. Then we look at the English health inequality strategy, which spanned the period 1999 to 2010. And that was a pointed policy to try and reduce both child poverty and pensioner poverty. And then we looked at the period of austerity between 2010 to 2017 to understand how it impacted on intergenerational correlations in health and what that means for health inequalities. And so then right now I'm going to just discuss 3 of our research projects, which I think will be relevant. So we're looking at the one that I just mentioned, was looking at how different policy approaches to health inequalities impact on geographical differences in mobility and health and wages for young people. And then we also look at the impact of poor health on the productivity gap between the north and the rest of England. So looking at how economics and health are related, why it's important that in order to have economic growth, you need good health. And we also did some research on who's likely to become food insecure because of the COVID-19 pandemic. So for all these studies, we use secondary data. So we use the household longitudinal survey, that the British Household Panel Survey, which was a survey of approximately 5,500 households and 10,003 individuals, which ran from 1991 to 2008. And then they had a follow-on survey from that, which significantly increased the sample size of the survey to 40,000 households, and also was more ethnically representative of the UK population. And of those people who were in the original survey, 6,700 of those joined this new survey. And we used 7 waves of data covering the period 2009 to 2016. And as well, we also used this survey, ran a COVID survey for a year, where they interviewed people every month to find out how they were coping with COVID in both their health, economic, and well-being and relationships and schooling and things like that. And that was approximately 17,000 people from the 40,000 original household members. And the outcomes that we're interested in are physical health, which we measured as self-assessed health, where people could report their health as very poor, fair, good, very good, excellent. If people reported having a limiting long-term condition, mental health, which we measured as the General Health Questionnaire 12, where if people report had 0, then it's worse mental health, and 36 is the best. We also looked at wages, the log of hourly wages, which just normalizes wages, and employment gaps, so that's how many people are actively employed. For food insecurity, we looked at any person in the household was unable to eat healthy or nutritious food, or hungry but did not eat. And so for looking at intergenerational inequalities, we compared the influence of parents on young adults' health and wages when their children were between the ages of 16 and 25 over the 3 different time points. So between 1991 and 1998, between 1999 and 2010, between 2010 and 2016. And we also compare the influence of parents' health and wages between the north and the rest of England to look at if there's geographical differences in mobility and what that might mean. And we measure socioeconomic status by looking at parents in professional and managerial occupations compared to parents who are working in manual occupations. And we also looked at educational attainment with parents with degree or higher versus parents with basic or no formal qualifications. And we also looked at 2 parents versus single parents households. And then to look at the gap in employment and health, we use a decomposition approach. So how much of the difference in employment gaps, that's how many people are in work between the north and the rest of England, can be explained by physical and mental health and limiting long-term condition. And then we estimate the association between mental and physical health and limiting long-term condition employment. And then we basically divide the coefficient from step 2 to find out basically how much differences in productivity impact on the fact, how much health explains the fact that the north has lower productivity than the rest of England. And for food insecurity, we use a regression model to look at the factors that influence 3 measures of food insecurity. And then we basically look at how potential mechanisms that might explain this, in particular financial vulnerability and social support, to see if people who don't have who are more financially vulnerable or don't have social support are more likely to report being food insecure. So the key findings is that we did find that there are regional differences on the role of health inequality policy and the influence of the family on young adult children's health and wages. So we found that during the English health inequality period, that was between 1999 and 2010, there was a larger decrease in the influence of parents on health and wages in the north compared to the rest of England, and that austerity had been worse on mobility in the north compared to the rest of England. and that mobility is increasing at a slower rate in the north of England, the rest of England, since 2010. And we also found that the influence of parents on their children's mental health is increasing in the north of England compared to the rest of England, where it has been decreasing over time. And then thinking about the productivity gap between the north and the rest of England, we found that 30% of the £4 per person, gap in productivity, or £1.20 per hour, between the northern powerhouse and the rest of England is due to ill health. Reducing this health gap would generate an additional £13.2 billion in gross value added, which is a way of measuring productivity. And finally, for food insecurity, we found that people who had basic or no educational qualifications who were unemployed in April 2020 were disabled or had lower household incomes were significantly more likely to report being food insecure, and that financial vulnerability explains approximately half of the likelihood of being food insecure for those families with children of lower socioeconomic status, as measured by educational attainment. And eligibility for free school meals, those who are furloughed and receiving help from grandparents, explained approximately 30% of the likelihood of being food insecure. And that free school meals was one of the most important of these three measures. And so then we have developed some policy recommendations based upon our research. So what we suggest is that local authorities, local enterprise partnerships, and health and wellbeing board systems should scale up their family-centered, place-based public health programs to invest more in interventions that reduce social and environmental inequalities, and that local enterprise partnerships, schools, third sector organizations, local authorities, and developed northern regions to develop locally tailored programs for young people, providing both health and employment support to help them into the world of work, as well as staying healthy at work. And there needs to be more coordinated responses between local health services to identify at-risk families and individuals at the time of disrupted health service delivery. And then for central governments, I guess kind of relating to the levelling up agenda, is there should be increased investment in place-based public health in northern local authorities. And that if the government is serious about the levelling up, then more funding is needed to increase the public health budgets in northern local authorities to facilitate the development and delivery of effective place-based public health. And there should be increased investment in northern schools, especially secondary schools, to reduce inequalities in educational attainment and the impact it has on family mobility in the north. And to reduce inequalities should be increased spending on economic growth and development in left behind communities. This growth strategy should be environmentally sustainable and socially inclusive. And as well, even though this is going to be stopped, that the increased generosity of benefits is very important for keeping people out of destitution, and that additional funding is needed for local authorities who are tasked with supporting people who fall in the cracks of central government safety nets, and that there needs to be the removal of excessive financial and practical barriers to obtaining universal credit and reduce delays in delivery of funded, as well as targeted job creations in economically vulnerable areas. So one of the other projects that we're working on at this moment is an evaluation of the Lighthouse scheme, which is a COVID lab in Gateshead, where they had, the NHS had targeted employment recruiting at those hard to reach groups and those who would not normally think that they could have an NHS job. So they went out to these communities. They also offered supported job centres for people to apply, and offered training to those who met the criteria. But I guess the whole difficulty with this is that they did manage to hire approximately 600 people, but then their budget was cut and they're going to shut the lab in March. So it's kind of things is a short-term fix, but it doesn't really create the longer-term economic prospects for those kind of in need. And as well, another thing that's very important in terms of food insecurity is increasing eligibility and amount for food voucher schemes to cover not just those pregnant women and very young children, but children up throughout school potentially. And I guess some of the challenges is the exiting the European Union in terms of future economic growth, staff levels, and uncertainty around post-Brexit NHS and local authority public health budget settlements, budget cuts, the lagging behind of public health and prevention expenditure compared with treatment of existing conditions, and innovative and inclusive growth to ensure that economic growth in the North is environmentally sustainable, is targeted at all individuals, community in the region, as well as the continuing uncertainties associated with COVID. So then just to conclude, we find that deprivation is rising in the northeast of England, and that health inequalities are increasing between the north and the rest of England, that health and social mobility for families in the north of England increased. So I guess it's not all bad news, that we did find that when there was a targeted approach to reducing child and pensioner poverty, that did increase social mobility in the north, but has been decreasing since austerity was introduced in 2010, and that improving health can reduce the employment gap between the north and the rest of England, and that in order to achieve the goals of increasing social and health mobility in the north and improving productivity, that investment is needed in education, public health, employment opportunities, as well as the NHS, and that it is a very challenging climate at the moment to achieve any of these objectives. And I think that is the end of my presentation, so I'll stop sharing.
Thank you very much for that, Dr. Brown. Councillor Rooney, you have a question, followed by Councillor Morstan. You're on mute, Denise. Still on mute.
Sorry, I was looking at the presentation. I pulled it up. On page 30 of your presentation, Heather, you talk about the £4 per person per hour gap in productivity, or £1.20 per hour. Can you explain that a little bit more for me so I understand it? Thank you.
Of course, so I'm just looking at it myself. So basically, what we did is that there are a few different ways of measuring productivity. So one of them is gross value added. Another one is just looking at, I guess, a simplistic one is looking at the employment rate. So what we did is you can get from ONS the gross value added for each local authority, and then you can basically do some simple back of the envelope calculations to determine what the difference is between the local authorities. So we kind of summed up the north of England based upon the Northern Powerhouse definition, because this project was funded by the Northern Health Service Alliance. And then we compared that to the rest of England, and that's how we came to that sum. Does that make sense?
Yeah, in part. I think I was looking at the £1.20 that's in
so that's
there.
Basically
And
population size.
That if somebody's income increased by £1.20 an hour, then that would have that big impact. Or have I missed the point?
No, so that's just a difference in. So if a person in the north is working, that kind of value added to the economy they produce is £1.20 an hour less than someone who's working in London.
That makes more sense now. Thank you for that. Can I just go on for another one, Councillor Cope, please?
Yes, go ahead.
And this is probably not for Heather, it's probably for us. In terms of free school meals, since universal credit was introduced, we've lost a lot of children on free school meals because they no longer qualify. Has our local authority done an assessment of how many children are impacted by that? I don't think Heather can answer that, but if I can ask for that question to go back to our team. Thank you. And thanks, Heather. Thank you.
Okay, thank you. Councillor Morstan, Tom, you've got a question, followed by Ron. You're mute, Tom.
Okay.
Perfect.
Thank you. Hello, Heather. Enjoy Lapland, Finland. I was there 15 years ago in December. It was fantastic. My query is really about the Northern Powerhouse. There's questions to whether we're feeling the full benefit of being a member of the Northern Powerhouse, and is it really having benefited this area, being as your figures are based quite a lot on the Northern Powerhouse. How can you answer that one? Difficult perhaps, but can you help me?
I guess I have been doing a few things around that. So there is there's a lot of heterogeneity in the north. So if you look at, you know, some regions around Manchester and kind of as well, you have those have high productivity and they're very different as well. Then you look at kind of the northeast, Blackpool, kind of bits of Carlisle area that they all, but it's, I guess, kind of the things that it's hard to say because really the Northern Health Service Alliance wanted, the reasoning, I guess, behind it is that if you have a larger area, then it will have more political clout. And that they had people like George Osborne was behind it, and that other people, you know, kind of who potentially could influence the central government, where if you split up into smaller sections, it's less likely to have any positive effect. But then what it actually has done, it's hard to say. It's more of a lobbying organization, I think, to draw attention to the fact that, you know, it's not just London and that there's other areas and that there's ways that you can, by increasing investment, you know, focusing growth, thinking about what these areas need, that you could improve the situation for them.
Thanks very much for that. Thanks, David.
Yeah, thanks, Tom. Ron, you have a question?
Yeah, I have a couple actually. Heather, firstly, are you a paid-up member of the Labour Party?
No.
I think that's inappropriate, Chair.
It's not for you to put in, Denise. Keep your nose out of it. The chair that runs this meeting, not you.
Well, I'm making a request to the chair on.
Yeah, I think Ron, that says perhaps a little bit embarrassing for the.
Well, it is embarrassing, but it seems to me the whole of this presentation is, it might as well come straight from Labour's headquarters. Now, you're an intellectual, Heather. I doubt very much you've ever mixed with the people that you talk about of being deprived and such as that. I have. And I don't think you quite understand what goes on in these places. You're going about health inequalities. Bound to have health inequalities when people drink too much, take drugs, smoke, don't take any exercise. You know, you're bound to get health inequalities. And that's not all based about how much money you've got. It's about a mindset. That's the difference. You don't understand that.
Can I put a comment? This shouldn't be an attack on the person doing the presentation who's been invited by the committee.
Yeah, I would tend to agree with that. I think Ron, that you're. I see where you're going with it.
I'll leave it at that then. If you think I'm attacking her, but I think it's fair to give a comment. We've had a presentation today, and I think it's a completely biased presentation. It bases everything on attacking the present government, and it's wrong. Okay, thank you.
Well, thanks for your opinion, Ron. Sorry, Heather. Yes, I can see where Ron's coming from, but really, no. You were here to tell us about that, and you give us a presentation, which we are grateful for. Thank you. Do we have any other questions for that? Councillor Rooney, Denise?
Thanks. I'd just like to say thank you, Heather, for the presentation. I know it's a bit difficult when you've got childcare as well. Right, the presentation at page 24 puts forward some recommendations for local authorities to look at. And can we take this opportunity through the chair and through the support staff to look at those recommendations and ask organisations like the TVCA, the LEP, the Health and Wellbeing Board to come and provide us with some presentations and information as to how they can help us deal with these inequalities. Because no matter how much how that information was presented, it is not just Newcastle University. There are other universities that have produced very similar information, particularly on child health and inequalities very recently. And I'd like to hear from our local organisations as to what they can do to help us and what barriers they're facing in order to help us, because not all of it will be about funding. Some of it will be about coordination and making sure the information is mapped up. So if I can put that forward, thanks, Chair.
Through you, Chair, if I can respond to Councillor Rooney, it's already in the plan there, Denise, so we will intend to get them all in, but don't worry, thank you, though, I will take that forward.
Chair, could I ask a question, please? It's Alma Hilawi.
Yes, Alma, go ahead.
Okay, fine. First of all, thank you, Heather. I think it was a brilliant presentation, and I think it's very, very statistically accurate, and I think the historical impact is very obvious about particularly austerity and lack of funding to the north. My question is really, or my reflection is a bit like Denise's, what on earth can we do to address this inequality? And as I analysed the presentation before the meeting, I look continuously for references to financial support, or in fact lack of. And the bottom line is really financial lack of investment in every respect, hit over the head as well by Brexit, as you clearly said. And I think that's the biggest challenge. Yes, I agree, Denise. We need to look at how we can get other agencies involved to try and address some of the inequalities we face. But the bottom line is we need so much more investment. I mean, even the Tory party talks about the levelling up agenda. Haven't seen much evidence of it, but that is the bottom line. We need more investment in a levelling up way. We need to have that money here to be able to improve the life and health of our residents across the town and indeed across the northeast. Thank you. I don't know if you want to comment, Heather, on my thoughts, because I was very impressed when I studied your presentation ahead of the meeting. Thank you.
Thank you. I guess just a quick comment. I was going to say, because that it was trying to be apolitical, because it is there. I guess it's recognised through all political parties with the statistical data that there has been lower investments in the north of England, and that is one of the factors that explains differences in outcomes. And I guess it is limited because this is statistical analysis, so you can only look at numbers. But in the numbers, there's a way that if you could kind of change, increase the amount of funding, then it's possible that you might be able to change some of these outcomes. And that's kind of what it is. If you can push this agenda, and as well show that there's both an economic and health reason for doing this, that it creates a case that it's something that should be done.
Yeah,
thank you. Yes, indeed. Thank you, Heather.
Yeah, one comment I would make is I know this is sort of generally the northeast of England covering, but as we've said in this area in the past, if we were going to get a massive funding, it would head towards Newcastle, stay there in Newcastle, and we'd get the sort of the bits at the end. And it's always been the same in this area that we know Newcastle does have its problems. There's no doubt about it. The whole of the northeast has its problems. But if it was centred on the north of England, it would go to Newcastle, and we wouldn't see an awful lot of it because that's the way things happen. So what are your thoughts about how the area should be funded? I mean, don't have to give your thoughts, but do you feel that it should be across the northeast, or should it be centred on various areas?
I think it should be based upon need. So it shouldn't be centred on the north, but should be spent, because the statistics are clear. So there's certain areas that need funding more than others, and that if it's based upon key indicators related to, say, child outcomes, health outcomes, that's how I would allocate the funding. So it's based upon need to ensure an equitable distribution of resources, which is actually what I'm going to be doing here in Finland, is I'm developing formulas to determine that.
Finland is a beautiful country. I was there about 12 years ago in Helsinki, around there. It is beautiful. I'm sure it still is. No, it's just I was just concerned that we know the problems we've got, and this is part of this report. This is why we're doing this, to find out where the areas are and where we can sort of help out and why we have this problem. And one of the things is that money seems to flow from a pot, and it sort of seems to end up on Newcastle's door more than it ends up in this area. So we just want to make sure that any report comes out is fair to us as it should be fair to Newcastle, Sunderland and Cumbria, etc. So we just want to make sure that does happen. Okay, just reading through your report, it is quite comprehensive, but I would like to see a little bit more done on Middlesbrough, as obviously with a health panel for Middlesbrough. I'd just like to see a bit more targeted on the problems in Middlesbrough and looking at those sort of areas. I see what you're saying about that, and if you do, I've worked a lot abroad, and no matter where you go in the world, you find someone from the northeast, especially from not only Newcastle, but especially from Teesside, because people leave the northeast with skills, because that's they're in demand, which doesn't help our economy. So it's something to entice people back and help and get the inequalities down, which is what we're trying to look at here. But thank you very much for your presentation.
Thanks.
Okay. If there's no other questions, thank you very much, and you can enjoy your children's video and things there. Thank you. I'm quite happy to stay for the rest of the thing if you want, but I think your children probably a bit more tug on your things at the moment. Thank you.
Yes, unfortunately they will be. All right, bye. Thank you very much.
Thanks, Heather.
Thank
Bye-bye.
you very much, Heather. Thank you.
Thank you.
Thank you.
Chair, I think Chris from the IPPR has joined
Yeah,
the meeting. I'll just
yeah,
send
I
him
can
a
see
quick.
Chris's. Yeah.
There he is. Excellent. There you go. Hi, Chris. Can you hear us all right?
Loud and clear. Hi, everyone.
Brilliant. Okie dokie. Are you wanting us to share your slides? Is that right?
Yeah,
to
would that
confirm.
be
Yeah.
would that be okay?
Yeah, that's right. Dan, can you call those slides up for me if you're there in the background, please? Thanks.
Yeah. Yeah, we have now Chris, Thomas, and hopefully Anna Round with health inequalities levelling up for prosperity. Chris.
My apologies, Chair, that I haven't updated you properly on that one. Anna Round's on a sabbatical, unfortunately, so it'll be Chris on his own today, I'm afraid, Chair.
That's fine. Over to you, Chris.
Brilliant. Great. So I'll just say next slide. Is that the best way when we move on? But huge thanks for inviting me to come and talk. It sounds like there's been a couple on this theme, and it's a good day to be talking about health and how it relates to the economy as well, given all the announcements this
Can I
afternoon.
just interrupt you 2 seconds, Chris? I can just see Dan furiously trying to find the right button to press. Dan, can you go to view at the top for me? And then go to full screen mode, just a little bit further down. That's it. And then when Chris says next slide, just press the down key and it'll move along for you. Thank you very much.
Perfect. So I'm going to be talking through a piece of research done by the Institute for Public Policy Research late last year on the interaction between the levelling up agenda, health, and some of the economic agenda as well that's been put forward by the government. For those that don't know IPPR, as well as others, we're the UK's permanent progressive think tank. So we're a registered charity and research institution. The work that we do is it's proudly cross-party. Our steering committee has members of both Conservative and Labour members at the moment. And we've been running a major health and care research programme now for the best part of 6 years. So I'll talk through that, but on the next slide, we just have a little bit of a summary about the Institute. If we could just move on one. Okay, look at that. So just a little bit of information about IPPR there. The really important thing about this piece of research is that it's not just from the IPPR Westminster team. IPPR has organisations based around the country. So we have an IPPR North outfit based in a combination of Newcastle and Manchester, although actually much more far afield now that the pandemic spread us out. And we also have an organisation, IPPR Scotland, working north of the border as well. If we go to, in fact, we can go 2 slides on this time, if that's okay. So a bit of context to the research that we put together. Essentially, our interest was thinking about what health and how health played a role as a variable in 3 key government commitments. So levelling up being one, and a quote from the Prime Minister there around parts of the country that feel left behind, talent genius, uniformly distributed opportunity is not. So our interest is if we take that word opportunity and think about how it interacts with health, what kind of implications do we see? We're interested in some of the really bold commitments that featured in the Conservative manifesto on health improvement. So that includes the broad commitments to improve health, deliver world-class outcomes, and to close health disparities, but also really interested in that quite totemic commitment, really, if it's achieved, to improve healthy life expectancy by 5 years by 2035. And given that this is research that comes during COVID, of course, very interested in how health inequality can be a unit of analysis and thinking through how we build back better. So in terms of how we don't just go back to the kind of health outcomes that we saw in 2019 before COVID-19 reached the shores, but could it be an opportunity to do better and to, you know, for a government perspective going to the next election with that in mind, or from an opposition perspective, could it be something that they should pick up as a policy agenda too? So if we go to the next slide. The first thing I'll talk through in the presentation is really our quantitative results, so what we showed in terms of how health needs cluster in places. I'll then come on to how we saw a link between those health disparities and economic opportunity. And then I can talk through some of the things that we suggested, and I'll break that into a national sense, a local sense as well. So different actions that different people can take. So if we start with the next slide. The starting point for thinking about how health clusters for us was thinking about what the overall national picture was. So how can we understand that? And what we see is that the UK has, broadly speaking, health population health outcomes that are at the life expectancy level, at least comparable with other high income countries. So for men, we have a slightly higher health expectancy, life expectancy than comparable nations in the EU. The HIC stands for high income countries in the OECD. For women, it's maybe a little bit more middle of the pack, but broadly in line with that average figure. But underneath that overall good is actually a much wider disparity in terms of different places and actually some of the larger inequalities within those groups as well. So if we go to the next slide. So what we see here is that at a very high level. So this is regional analysis. There was local authority level analysis in the report as well. But this is interesting as a chart because it shows under 75 mortality rate for every 100,000 people. And what we see is if we look at the top, we've got the North and the Midlands, and across those different types of under 75 mortality, we see that broadly the rates are fairly significantly above the England average. And we see that if we look at the east of England, London, southwest, southeast, then the rates are pretty uniformly below the rates at the England average. Under 75 mortality is interesting because as much as this is a sense of a challenge, it's also a sense of an opportunity. Under 75 mortality, I'm sure many know, is generally considered the level at which mortality becomes preventable. So where there are things that we can do either by intervening in social conditions in a very downstream way or through better healthcare interventions where things could have been prevented or that instance of mortality could have been delayed. If we go to the next slide, we see this clustering of need intersect with different drivers. So both what are often called, I suppose, behavioural is often the word that's used against them, but we'd suggest that behaviour has its own social elements. And in this case, we see a clustering of obesity, which is just something that we spotlight in the report. But you'll notice that that same divide across the country, place-based divide, is seen in obesity as it is then in premature mortality. And this is us just trying to draw that line of trajectory from the preventable mortality. This is one step back to obesity, and we can see and draw similar patterns with other aspects that we know have links to preventable mortality, including things like alcohol and exercise and diet, which is interesting. The thing I didn't touch on in the last slide that I should have done is that the local authority analysis that you see here is consistent with the premature mortality. So we actually see that something like six of the local authorities that are in the highest levels of all-cause mortality are actually their premature mortality is highest across the board for heart disease, for cancer, for everything we looked at. So the consistency with which health clusters in the same places is really something that we picked out. If we go to the next slide, we also see that isn't just happening in isolation. It's absolutely happening in tandem with social needs. So across the chart that we see here, the regional analysis, also if we go down to a more place-based local authority analysis, then we see that that factors like deprivation, fuel poverty, job density, skills, disposable income, wealth and income inequalities, those tend to be very, very well overlaid against places where need tends to be highest. And this speaks to us very strongly, both in that terms of, is there a link between the economy that we have in the health system, thinking about a public health system that we have, which is really interesting, but it's also a really good indication that some of the solutions need to come. Not as much policy in the last 20 years is focused at the personal level, so what can individuals do, but at the more structural levels, so how can we impact some of these variables that we know from a rich body of evidence have very strong links to health outcomes. How can we use those as variables that we can have an impact on? So if we go to the next slide. So that's the first unit of analysis, is to say that there is a real strong sense that, let's see, the slide's flicking on, but a really strong clustering of health needs and really strong overlap of the clustering of social needs in the same places. And what we wanted to work out was whether we could draw then a link between the economy of those places. And there's a lot of conversation in health research around the social determinants of health. And that's really important because it gives us a sense of what beyond NHS services we can do from a policy perspective to change the health of people over their life course. But there's an equally interesting way of looking at it, which is, I suppose, what you might call the health determinants of a local economy, and something that ties in very well with some of the community wealth pilots and experiences that have been seen across the country. So this shows one of a few indicators that we point out in this case, the interaction between long-term conditions and work. And what we see here is two really interesting patterns. One is that people with a health condition that we can define as chronic are less likely than the England average to be in work, but also that in some places that impact is moderated. And if we look at places where some of the social deprivation that we talked about was highest, and again, true at regional and local levels, then what we see is the impact of having a long-term condition being slightly higher in its impact on work, which is an interesting moderating effect. If we go to the next slide, we can also see an association between the kinds of premature mortality that we were talking about and productivity. So on this slide, we've taken the indices for productivity, which is essentially gross value added per hour worked, and mapped that against the kind of under 75 mortality that I showed in one of the earlier slides. And what we see, you can see the line of benefit there, is that there's a strong correlation here between mortality and productivity. If we go to the next slide, then we can start to talk about this in terms of its kind of cost-benefit analysis, I suppose, its national implications. And this essentially shows our employment of a methodology first pioneered by the Northern Health Science Alliance in 2017. And what they showed was that £1 in every 3 of the GVA gap between the north of England and the rest of England was explained by health. That came at the time that they did that analysis to around £13 billion worth of what you might say is cost, or you could also say is opportunity. If there was more equal health, then that would be the economic benefit. Our updated analysis showed, and thinking about the last graph that I showed, that figure now stands at 20.2 billion per year. So that's the kind of prospective opportunity there is from that very raw economic perspective if health inequalities were closed between regions in this case. If we go to the next slide, we can go one on, in fact. We combine the quantitative analysis that I've just talked us through with a sustained qualitative process, so focus groups and interviews, to try to work out what some of the ideas were for national government and for local government that would help make some progress on inequalities. And the standing question here is really about why it's so difficult for progress to be made. We know that there's amazing evidence defining the problems of health inequalities, and I think there's been more than just mine presented here today. You can trace back to as early as 1066 evidence of health inequalities and a sense of why health inequalities emerge. So the fact that there's social determinants of those differential outcomes. So it's a long-standing problem, but progress has been incredibly difficult, and particularly since we've had modern data, we haven't seen huge amounts or any real instances of that gap being closed hugely substantially at the healthy life expectancy level. So the ideas that we came to were around instruments that not only help make progress, but also help incentivize the right policy decisions. And that's very much the theme of those first two concepts. The first is measuring the right things. So very strongly, our work indicated that one of the things that's really challenging with health inequalities is that you don't tend to see a benefit against the measure we do use, GDP, very quickly. It tends to be that health inequalities progress in a longer term way than electoral cycles. And also that, frankly, if GDP is the thing that defines the agenda beyond anything else as an output measure, it's not a very good predictor of how healthy a place is. So it's not conductive to leading, say, a Chancellor of the Exchequer to the right investments from a health perspective, even if from an economic perspective, it might have its own merits. So one thing that we point out, and a long-standing IPPR call besides, is that we need a more concrete sense of what prosperity looks like. Something like the ONS's new health index, which becomes a national statistic in the autumn, would be a fantastic way to complement GDP, both for local leaders and for national leaders, to be honest, because it does break down at the local authority level, and to make sure that the decisions that are being pursued take into account not just GDP, but also the distinct health consequences of different actions. The other thing that's quite interesting in measurement is age, and how age is used, particularly within the NHS. So age is used as a predictor of need. So it's a really good predictor of need. If you have the age of someone, you can probably predict whether or not they'll need to use a healthcare service. What it doesn't measure is unmet needs. So whether someone will need a service but won't use it for whatever reason. It might be, it's remarkable how many bus stops are at the bottom of hills, hospital bus stops. So those kinds of barriers can stop people coming into the NHS. And so there's a sense and an aspect of this, which is to what extent should the NHS be measuring deprivation and then using that to allocate its funding, which was the case slightly more strongly in 2013. The allocation weighted by deprivation was reduced at that point. So our recommendation, one of the first recommendations, was to increase the weighting of deprivation back to 15%. In terms of making health an aspect of policy decisions, so if we measure health, it's very important that it then does bear on local national policy. We suggested health impact assessments. So we're very good at doing within, officials within England, very good at doing health economic impact and spending assessments. And there's all kinds of treasury books that cover how to do a good impact assessment. But health is not often contained. It's not a distinct feature even in the 2012 Social Value Act. So training and support and protocol for systematically looking at how different policy decisions across places, across Whitehall, impact health, we think would be an incredibly useful thing. Third, community building. So the government are bringing forward integration and their new NHS social care legislation, which will devolve powers over health to integrated care systems. I'm sure there's been lots of consideration of that. And we think that's a really promising move, but we also think that it needs to be combined with community health building. So if there's no one for the NHS to integrate with in places where health need is really high or deprivation is really high, then we think that's a problem and puts places at a big disadvantage to, say, an affluent London neighbourhood where there's lots of charities and social enterprises and businesses. So we think investment in places where there isn't that infrastructure really important. And the last thing is the public health grant, and I'll move on to the next slide to talk this one through. So I've spotlighted obesity as something that's interesting, or that we found interesting. And in this table, we just have a sense of how the cuts to the public health grant have played out over the last decade. We see cuts per person that are very different in certain parts of the country. Wider IPPR analysis suggests that if we then go to the local authority level, that actually most of the cuts fell on the most deprived parts of the country, probably because their budgets for the public health grant were slightly higher from the outset because of that extra level of need. But the really worrying thing is not just the immediate health consequence, the COVID consequence as well. We found in this paper that places with the highest public health grants also had the highest COVID deaths, and that's because public health grants are really good ways of addressing the underlying health conditions that would later put people at risk. So we think restoring those services and making sure that the places that had the highest cuts are restored in full And worth saying from a Middlesbrough perspective that was one of the areas that came out as having a particular kind of benefit. Should that policy be enacted, then that would be a really good idea as well. If we go to the last slide. We also looked quite strongly, and as you can imagine, IPR working with IPR North at ideas that we thought local government could take forward. And it's worth saying that there was throughout, we did lots of case study work. We did lots of, as I say, qualitative work. There was a real sense that local leadership often significantly outpaced national leadership. So there were really promising examples that back some of these ideas up. But 4 ideas to summarize. One, that community health building theme as well. We've seen community wealth building in places like Preston. We think it's worked quite well. We think that equally you could use the very same tools, things like procurement budgets, to deliver good health outcomes by making sure that places have, procurement suppliers have subscribed to the right health standards. That might be that they have health conscious levels of pay or employment standards, or that they subscribe even to the National Institute of Healthcare Excellence's own criteria for what healthy employment looks like. The second thing is a focus on relationships, not rules. We know that there are health powers coming down the line. Our work very clear that as much as governance will be an important aspect of thinking through next steps, it was relationships that enabled local areas to really nail health improvement schemes, and that came through very strongly from analysis in Wigan, GM, of course. So working out where those forums are really important, and how those can in some cases help get around some of the things that aren't useful at a local level but are implemented by a national level. That came through as a very strong idea. Third, after a diagnosis, we often see health as almost, prevention has failed once someone gets a diagnosis, but we saw huge opportunities here in working with people with chronic long-term conditions, particularly around work and accessible work for those groups. And lastly, the same point on how decisions are made and bringing health and deprivation to bear in those decisions again. That came through very strongly, and that doesn't need to wait for Whitehall. That can happen at a local level already and in advance. That's the summary of the report, the findings, the recommendations. Very, very happy to answer questions and interested to hear what you think.
Yes, thank you, Chris, for that presentation. One thing that struck me about that is you go into areas about deprivation and things like that, but what about solutions to that? Because people traditionally in this area, the mortality rate used to be you retired from the steelworks at 65 and were dead at 66, which was a terrible thing to say. A lot of the things have changed, things have improved. The steelworks have sadly has gone, but it's still a problem in this area. And is it down to lifestyle? Is it down to people not wanting to get part of the health service, or is it a lot of it's due to, obesity can cause a lot of problems, and it drags other things in with cancers and things like that. So do you feel that it's more education wise, or is it more help wise, or is it just a case of having to build up the service to the extent that people will take it up? And what happens if people still don't take it up? What I'm trying to get at is, how do you get at the people that you need to help? Because once they have cancer, it's treating. If you get them before they get cancer, then it's preventative. So how do you look at that sort of area? Thanks.
Yeah, really good question. The really clear finding is that if the and you're right, it's a particular challenge in an age where life expectancy has gone up very quickly, but healthy life expectancy hasn't. But if you are to, or were to just build services, particularly just healthcare services, and wait for people to come, then that's a really good recipe for inequalities emerging. There are very few case studies that are genuinely very powerful in their evidence that are that work at that kind of individual responsibility level and supporting that individual responsibility. What works really well is where there is some kind of formal infrastructure to help with coordination, combined with things that go beyond the health sector. So one example, one case study that came up very strongly was the Improving Cancer Journey pilot in Glasgow, and that was run and funded by Macmillan Cancer Support between around 2014, 2017 was the first evaluation. It was quite simple, really, as a scheme. What it did was, once someone developed a chronic diagnosis, so the thing that would suppress their healthy life expectancy in that period, they were given a named advocate or link worker who was responsible for helping them to coordinate different services in the community, in the NHS, charity, social enterprises, whatever it might be, who was responsible for making sure that they had the kind of ability to bring their preferences and priorities to bear on what that care plan looked like, and that they weren't blocked from access because of, it could be anything from financial to psychological, whatever reasons it might be. Really importantly, that was located not somewhere kind of institutionalized or medicalized, that was located in the community. So it came to people, it came to high streets. There was the ability for link workers to come to people's homes. And the evaluation was just incredible. The number of people that were accessing help from the most deprived parts of Glasgow it was overwhelmingly from the most deprived parts of Glasgow. And the evaluation on the needs index of people coming in, on average, when someone came into the service, they had a need index of 7.5 out of 10, which suggests high levels of anxiety, high levels of need that go beyond their cancer diagnosis. By the time they'd finished with the scheme, they normally reported an average of something like 3.5, which is rounded. But that's a pretty significant improvement, and the kind of principles that can be extrapolated out of that are that taking a very holistic view of someone with a long-term condition, really important. Those social interventions, really important. They don't have to be expensive. They can be existing infrastructure, and it often actually helps to support the kind of infrastructure in a place. But locating it in the community was the really important thing as well, making sure it was coming to people rather than, kind of being located in a come and get us style of fashion.
And just one last comment with that. There was a case a few years ago where people, if they're sort of obese or certainly morbid obese, they were saying, well, we're not going to treat you and things like that. Well, surely that's the opposite thing to take. A, don't let people get into that condition in the first place, but B, try and help people out if they're in that sort of condition. I know a friend of mine was. He got wonderful treatment in James Cook. When he went further north, I think the treatment wasn't as good. But having said that, it should be a holistic approach. You shouldn't just sort of write someone off just because they were obese. So you've got to look at the problems, look at exactly what you're saying, look at the whole aspect of this, look at the lifestyles, look at people's inequalities, and try and address that as a problem. So I can see where you're coming from with that.
Yeah, I think it's an excellent point, and the empathy of the approach as well is really important. Touching on the idea of people being denied services for obesity, which I think was, if I'm right in thinking, I think in York, and other places as well. And it's interesting again in the evidence that there's a clinical cost to approaches that are focused either on blame or what you might say stigma. Lung cancer has always been a really good example of typifying this. And what we see is not only do people who have lung cancer and did smoke, so have that sense of stigma, experience worse clinical outcomes because of it. We actually see people that didn't smoke experience worse clinical outcomes linked to stigma as well, which is an interesting finding and suggests, I think, that kind of encourage, help, empathize over blame, deny, prevent kind of approach that sometimes gets touted with.
Okay, thank you. Any other questions we have?
Can I ask a question, please, Chair? It's Alma. Hello.
Yes, Alma, go on. Go ahead, Alma.
Thank you. Chris, I made a note when you were talking about a financial situation, about local economy and community wealth. About £1 in every 3 was a gap that ended up with a 13 billion cost in health before, which is now escalated to 20.2 billion. Could you just talk a little bit more about that, please, to give me a bit more clarity and understanding of these figures?
Yeah, absolutely. So the figures derived from so a Northern Health Science Alliance paper found that there was a 33% explanatory power of health inequalities between the north of England, the rest of England, in the gross value added. So the what you might say the productivity gap between the north of England and the rest of England. So in the moment that they did that study, 2017, that would equate to £13.2 billion cost to the national economy of just the inequality, health inequality between the north of England and the rest of England. Upgraded to how that productivity gap has grown since that study, it now stands at 20.2 billion. So you can essentially conceive that figure as the economic reward on offer, or the economic cost that's currently in place of the health disparities between the north and the rest of the country. And what's really important to say is that that doesn't cover by any means the full gamut of health inequalities, their economic costs. So we know that there are many more lines and dynamics on which health inequalities can occur. So actually that's a very specific part of what could be a much bigger economic benefit of getting health equality right.
So could I just ask as a follow-up then? So are you really saying then, Chris, that if we were to address the health issues more appropriately, then there is a potential huge saving of something like 20.2 billion or more pounds if these issues were carefully addressed and they were successfully addressed?
Yeah, that's right, and that would be at a national level, but you can, as you would imagine, those benefits would fall on the places where the inequalities were solved as well, so where the health improvement actually happens.
Yes, that's what I was thinking. Yes, okay, thank you. Yes, I fully understand that now. Thank you for that clarification, Chris. Many thanks.
No worries.
Okay, thanks, Chris. Any other questions? One thing I thought of, Chris, is when as the health was around here a few years ago, as it is now, which is up to improvement, one thing we don't seem to use enough of is smaller clinics and things. Is well-man clinic, well-woman clinic. I was told, oh, we don't do well-man clinics, and that was the end of that question. So I would personally have thought that a lot of people would quite happily go to a clinic if it was at One Life Centre or something like that to go in just to have a general checkup than they may do trying to get a doctor's appointment, which is pretty difficult at the moment. So what were your thoughts about something like that to encourage more and more like a centre either at a doctor's surgery or things like that? We've done so well with COVID injections. Couldn't we turn the abilities of that into actually looking at the population and saying, please come along, you can come along to, if you're 60 or 55 or whatever, and that would actually see in the population, because at the moment, if someone doesn't go to the doctors, we don't know that person's ill. And what we want to do is get it before it's too late.
Yeah, I think it's really powerful. And there's lots of examples of that working well. So there's a couple of ways that the trajectory is moving. So we're seeing stronger evidence-based emerging around bringing some services outside of that hospital setting, which for some people can present barriers, and into community settings, including things like community diagnostic hubs, essentially bringing tests that can be used for things like cancer diagnostics into the community where before they would have been set in hospital. In some cases, those things can be mobile as well, which is quite interesting. So we've seen in pilots very good results from lung health checks being put on essentially buses and taken to supermarket car parks. And lung cancer is one of the leading causes of overall health inequalities. So a really nice targeted initiative, but brings it into a place where people can access it, or indeed just see it. So that works really well. There's a lot of promise with hub models as well. So what we've seen in some parts of the country is general practice combining with other providers. So it could be the local authority in terms of the social care assessments that they do with people. It could be charities in terms of some of the services they provide. It could be social prescribers, so people that take care of some of the more holistic needs that people have. And co-locating in that way makes the services more accessible, because you can combine things at once. It might prompt people but they've shown really good promise. And there are a few models out there that are really good exemplars. So I think, in summary, David, I think there's a lot of promise there, and something definitely to consider.
Yeah, I think I remember years ago that there was a skin clinic came round, and it was in the car park of Asda at South Bank, for example, where it used to be. And then that stopped. And I think it's things like that which are important. You could literally just turn up, go in, and someone who might be worried about a mole or something like that, well, as I know people who have died from skin cancer and things like that, if you get it early enough, there are treatments. And I would have thought something like that, the more cost effective. As I said, we've set up a fantastic system to deal with COVID. Surely, hopefully, when COVID is over, or even before COVID over, because we don't really want to get it, any further than it is, to set up these mobile clinics and things. I think that personally would be an excellent idea.
Agreed.
Thank you. Any other questions? I don't see any. In that case, thank you very much for your presentation. It was really comprehensive. Can you send us a copy of that to Scott, and then we can read it, etc. So
yeah, delighted to, and thanks for asking.
Excellent. Thank you.
Sorry, Chris. Thank you.
Thank you. All right. The next item is the OSB, which I have a copy here, which I might have put my glasses on. There it is. It's getting a bit dark in here. So right. At the last meeting of OSB on the 26th of July, the Chief Exec provided updates on the Council's continuous response recovery from COVID. Executive decisions made and made in July and August, staff communications, children's proxy indicators, and Middlesbrough Council matters. In terms of COVID at the time, the meeting stood at 854.7 per 100,000. We notice that's dropped a bit. It's gone back up to 402 today. Although it is noted that cases now have been declining, vaccination rates still show Middlesbrough to be low on the respective league tables, as we've again seen today. However, this information that didn't take age or demographics into account, making direct comparisons is difficult. It was also noted that a significant proportion of over 50s had only had a single dose. That's obviously been updated now, but we can still see that it's still people in the 40s and 30s that are not doing that. OSB was also advised that staff communications and engagements would be re-examined, which would see the development of consistent tools to provide staff and wider strategic objectives. In terms of Middlesbrough children's matters, whilst the recent Ofsted monitoring inspection offered reassurance that we were improving in children's services, there was a need to look at our commitment for all young people. As such, the Chief Exec and Director of Children's Services advised that 10 priorities were now in place, ranging from places where young people felt safe and proud to be where they lived, to best start in life, where families are supported to give young people the best start in life. Director of Children's Services also advised OSB on the final progress of financial progress of children's services, and informed members progress was being made to reduce service costs, which including reducing reliance on external residence placements, increased use of internal fostering placements. OSB was advised up to that point Children's Services was realising a slight underspend in its budget. Finally, the board also received updates from the panel chairs on the activities taken within their respective units. Does anybody have any questions or update? No. Is there anything else anybody wants to bring towards the panel? In that case, I'd bring the meeting to an end. Thank you all for attending, and I hope, as I did, we all got something out of this. Thank you.
Thank you, Chair.
Thank you.
Bye all. Bye.
Bye.
Bye bye.
Bye.